Welcome to CleanMedKE, where we make clinical medicine and surgery clear, structured, and clinical. Today, we're diving deep into the respiratory system, a journey from the anatomy of the upper airway down to the molecular dance of gas exchange. Before we start, a quick medical disclaimer. This video is for educational and informational purposes only and does not constitute medical advice. We begin by dividing the respiratory system into two main zones. First, the conducting zone. Think of this as the hallway. It warms, moistens, and filters the air using the nasal cavity and sinuses. As we move down past the pharynx and larynx, the epiglottis acts as a gatekeeper, sealing the airway during swallowing to prevent aspiration. A key clinical note, the right primary bronchus is wider and more vertical than the left, making it the most likely destination for aspirated foreign objects. Finally, we reach the respiratory zone, where the cartilage of the trachea disappears and smooth muscle takes over in the bronchioles, leading us into the terminal and respiratory bronchioles. Zooming into the alveoli, we see a specialized cellular landscape. Type 1 pneumocytes are the thin, squamous stars of the show, making up 97% of the wall and serving as the primary site for gas exchange. Type 2 pneumocytes are the maintenance crew. They secrete surfactant to lower surface tension and prevent the alveoli from collapsing. We also have alveolar macrophages, the janitors that engulf debris, and club cells in the bronchioles, which act as stem cells to regenerate the epithelium. Breathing is a game of pressure. At rest, your intrapulmonary, or alveolar pressure, is equal to the atmospheric pressure at 760 millimeters of mercury. However, the intrapleural pressure, the pressure in the space surrounding the lungs, stays negative at 756 millimeters of mercury. This vacuum effect is created by the lungs wanting to collapse inward while the chest wall wants to pull outward. This difference, known as transpulmonary pressure, is the positive outward force that keeps your lungs inflated. So, how do we actually move air? We use Boyle's law, which tells us that pressure and volume are inversely proportional. During inspiration, your diaphragm contracts and moves downward, increasing thoracic volume. This causes intrapulmonary pressure to drop and air flows in down the gradient. Expiration is usually passive. The diaphragm relaxes, thoracic volume decreases, pressure rises, and air is pushed out. Two critical concepts in clinical practice are compliance and elasticity. Compliance is distensibility, how easily the lung stretches. Elasticity is recoil, how strongly it snaps back. In pulmonary fibrosis, high elasticity and low compliance make it very hard to inhale, creating a restrictive pattern. Conversely, in emphysema, elastin breakdown leads to high compliance but low elasticity. These lungs are floppy and easy to fill but hard to empty, leading to obstructive disease and hyperinflation. Flow is determined by the pressure gradient divided by resistance. Because resistance is inversely proportional to the fourth power of the airway diameter, even small changes in diameter have huge effects. Under sympathetic, fight or flight, control, norepinephrine hits beta-2 receptors, causing bronchodilation to maximize airflow. Conversely, parasympathetic activation releases acetylcholine, binding to muscarinic receptors to cause bronchoconstriction. At the alveoli, oxygen and carbon dioxide must cross an astonishingly thin blood gas barrier. Oxygen diffuses down a steep pressure gradient from 104 millimeters of mercury in the alveoli to 40 millimeters of mercury in the blood. Interestingly, while CO2 has a much smaller pressure gradient, it diffuses at the same rate as oxygen because CO2 is 20 times more soluble in plasma. If this barrier thickens, such as in pneumonia or edema, this delicate exchange is severely hindered. For efficient gas exchange, we need VQ coupling with a normal ratio of about 0.8. If we have poor ventilation, like a mucus plug, the body reacts by constricting pulmonary arterioles to divert blood to better ventilated areas. If we have poor perfusion, like a pulmonary embolism, the bronchioles constrict to divert airflow to areas with healthy blood supply. It's the body's way of ensuring no resources are wasted. Oxygen transport relies on hemoglobin. In its T state, tense, it has a low affinity for oxygen and is stabilized by 2,3-BPG. However, as the first oxygen molecule binds, it triggers a conformational change into the R state, relaxed. This is positive cooperativity. Once one oxygen binds, the second, third, and fourth become progressively easier to attach. When blood reaches the lungs, the Haldane effect takes over. As oxygen floods in and forces hemoglobin into the high-affinity R state, the molecule's affinity for CO2 and protons drops drastically. This causes CO2, H+, and 2,3-BPG to be aggressively unloaded, allowing CO2 to diffuse into the alveoli so you can exhale it. How does CO2 get to the lungs in the first place? Only 10% is dissolved in plasma, and 20% is bound to hemoglobin as carbaminohemoglobin. The vast majority, 70%, is transported as bicarbonate, HCO3-. Inside the red blood cell, the enzyme carbonic anhydrase converts CO2 and water into bicarbonate. To maintain electrical neutrality during this process, the chloride shift occurs, swapping bicarbonate for chloride ions. Clinically, we measure these functions using spirometry. Tidal volume, TV, is your normal, quiet breathing, usually around 500 milliliters. Beyond that, you have your inspiratory, IRV, and expiratory reserve volumes, ERV, for forced breaths. Crucially, there is always a residual volume, RV, of about 1,200 milliliters that stays in the lungs to prevent collapse. This volume cannot be exhaled. By combining these volumes, we get capacities. Your inspiratory capacity, IC, is TV plus IRV. Your functional residual capacity, FRC, the air left after a normal breath, is ERV plus RV. The most important clinical metric is often vital capacity, VC, which is the total exchangeable air in your lungs. When you add everything together, including that residual volume, you get your total lung capacity, TLC. That wraps up our blueprint of clinical respiratory physiology. If you found this structured breakdown valuable, please like, share, and subscribe to CleanMedKE. Your support helps us keep medical education clear, structured, and accessible for everyone. Check out our other videos to continue mastering the clinical blueprints. Thanks for watching, and we'll see you in the next one.